Well, I just want to ask you that, Dr. Hegde, and behind me at the LNJP hospital, there's a siren, an ambulance a minute. We're really in a cataclysmic crisis. And what I want to ask you, Dr. Hegde, is all the obsessive focus on remdesivir taking away from what really matters, which is the lack of oxygen? The lack of oxygen, the lack of high flow oxygen is where our conversation should really be. And I know before we started the show, you were talking
Yeah.
about what's happening in your clinic. And I really want everybody on the panel to hear this. So go ahead, Dr. Hegde. You were talking about patients in your clinic with very low SPO levels having to share oxygen cylinders. Please speak about that.
See, in the last, 15 days, things have basically gone southward. The number of cases has significantly increased. There is a lack of doctors because a lot of doctors have discontinued their outpatient and they prefer only seeing inpatient. As a result, most cases are left undiagnosed. Patients do not receive any form of treatment. By the time most of them reach me in my own outpatient department, I must be one of the few doctors who's still running a COVID OPD. So I see about 300 cases every day since the last 1 year. I've probably crossed about 35,000 cases in OPD so far. And in the last 15 days, we have realized that the number of cases coming to us are not just more, but they seem to be more severe. And probably part of it has to do with the severity of the new strain. We're seeing more younger lot of people who are having, the case which I was explaining was, yesterday in OPD, I must have had about 270 patients. In that, there were about 3 kids who walked in. One of them was 28, another one was 30, and a third one was 33. All walked in with a saturation between 30 and 60. I have only one backup concentrator that I usually keep, which I usually don't even have. It's just last minute that I decided to have one. And I had to use the same concentrator between the 3 patients just to make sure that no one dies in that. And the biggest drawback is there is no ambulance, there is no hospital bed. I spoke to a lot of the authorities on the BMC war room number. I spoke to all my confidential little doctors, and almost all hospitals are full. And because the 3 of them would require NIV, oxygenation, and an ICU, the BMC just told me that they just didn't have a bed. And the only solution was temporary to keep the patient at a non-COVID setup till we find a bed in a COVID hospital. And eventually, I had to discharge 3 of my own patients from my DCH hospital and make place for them. The other problem is that the smallest COVID setups across here in Bombay have all run out of oxygen. So now most of them don't really take any patients which require oxygen. Their cutoff is basically to admit the asymptomatic ones, but that doesn't really help serve a purpose because a lot of patients who require oxygenation currently do not have a bed. And home oxygenation, earlier an oxygen concentrator in Bombay used to cost about 4,000 rupees for a rental period of 1 month. Now the rate is about 35,000 in just 15 or 20 days. And that too, there is no guarantee whether that will be available to you or not. It may take about 2 to 3 days because there are way too many people who are trying to use home oxygenation now. So I think very soon, including hospitals like mine, are on the tenterhooks because there is no guarantee of long-term supply. When it comes to remdesivir, at least there may be some scaling up from the companies. But with regards to the oxygen, the basic threshold of supply itself has been reached by the government. So unless some of the private industries were to pitch in, right now things look a little bleak. And the fear is like just what happened in Nasik is that a 100-bed DCH hospital like us, if it starts to run out of oxygen, it's going to be very difficult to manage or to transfer 100 patients out. And being a DCH hospital, in our hospital, we do not take asymptomatic cases. So almost every patient who's admitted is more than at least 5 to 7 liters. That's our basic cutoff to taking admissions here. So almost every patient here is between 5 to as much as 85 liters on a high flow nasal cannula. So in case we run out of oxygen, yeah, we're going to have a very tough time. So we have made some changes. We do not try to take in patients who require too much of oxygen, but sometimes you cannot choose because the patient may come in with only lower oxygen requirement, but probably in 24 hours, he may go into a cytokine storm and the requirement might suddenly shoot up. At the same time, the alternative is to use a lot of NIVs and BiPAPs, but we are anyway short on ventilators as far as our private hospitals are concerned. So we cannot really use an NIV on almost every patient. So in case if the oxygen really goes down, we do not really have an alternative here. So we take it in
It's
writing
chilling.
from the patients that such an event may happen in the foreseeable future. So they better be aware when they admit the patient with us.
Hang on. So when a patient already sick, low on oxygen, comes to you, you make them write a consent form that you may not have enough oxygen to save their lives. I'm paraphrasing you, but that's what it is, right?
Yeah, that's how exactly what it's going to be. For the simplest reason is that when we are down to 10%, we ourselves cannot be sure when we're going to run out. because it's just a mathematical calculation that 100 patients are going to be using anywhere between 5 to 85 liters. You yourself cannot be sure whether you're going to last that long or not. And because we are a DCH hospital, we are working 24/7 since the last 1 year. None of us have really had a break. We're working about 18 hours a day now for over a year. I mean, most of the staff is exhausted. People are on their tenterhooks. Most of the staff who fall sick don't want to join back. People seem to get stressed out. The families of the staff are stressed out. People who have, there's a risk of getting COVID even after you're being vaccinated. I mean, if people are of the opinion that just because you're vaccinated, you cannot get COVID, no, you can get a much milder form. So, when you compound all the factors put in together, whether you have less drugs, where you have, almost oxygen, where you're not really sure whether it's going to last or not, it does make even the treating team a little edgy, So that's exactly why, we do have to sometimes take it in writing. We don't like to do that. But at the same time, if we do not inform the relatives tomorrow, they would say that we never told them that this can happen. So that's exactly what we're trying to do. We're not like going to take it against them, but we need to inform them. That's an informed consent that we're taking.
But I'm just chilled to hear what you're saying, because it's true, of course, but this is where we are. We are making patients fill in forms saying, yes, we may die because the hospital doesn't have enough oxygen, so don't blame the hospital.